Well, thank you so much for the invitation, and it's a pleasure to be with you. One of the strange things, of course, about our modern world that we all developed during COVID is that being with you is actually sitting in my office here at UCH London, just gone 7:15 in the morning. Sun's actually shining today. Yeah, look forward to meeting up in real life. In fact, one of my other little phrases is the future of meetings is meeting, and one of the joys of our world community of endourology is all of the friends that we've made over the years. So the question, where did the term endoluminal endourology come from? Well, sort of on the one hand, I kind of made it up and popularized it, but on the other hand, it's kind of always been there, and it's pretty obvious. But the history of it, so observations that I've seen during my career as an endourologist and now as an endoluminal endourologist is that the scope of endourology is increasing all the time. So not just with our telescopes, but the depth and breadth of what an endourologist can do. And having qualified as a stone surgeon, and when I started my consultant practice, that was most of what I did. And now it is only really about a third of what I do. All of the other things, oncological obstruction, stricture, diagnostics, upper tract TCC. So stone surgeons really don't just treat stones. And endoluminal endourology is what we can do with a scope. So I think this really kind of says it. The syllabus for urology, urology is endourology and everything else. And actually the everything else is getting smaller and smaller, even reconstruction and andrology. Our andrology colleagues here at UCH are using robots for lymph node dissections. Reconstruction, of course, is happening with robots. So that really meant that endourology is urology. That is everything. And then the division I thought was pretty obvious. Endoluminal it takes place inside the lumen. So that's TURPs, TURBTs, ureteroscopies, PCNLs, all of the thing that somebody like me as a previous stone surgeon and now an endoluminal endourologist does. And the brother or sister, if you like, of endoluminal, which sits under the endourology hat, is exoluminal. That's laparoscopy, robotics, where it's endourology, but the operation takes place outside of the lumen. That's how I saw it. And in about 2015, I started calling myself an endoluminal endourologist to spread the word.
So my second question is, since the coining of this term, what is the trend that you noticed when people started to use this terminology, and what does this mean for endourology?
This one makes the point, as I've just mentioned, endoluminal and exoluminal are brother and sister, sit under the overarch of World Endourology, Endo Society. In fact, Endoluminal has got its own journal now, and this is a phrase I've not coined, but everything else is exourology, as in not endourology, and may even soon be ex-urology, because pretty much everything comes under the endourology banner.
And I'm so interested in the terminology exourology.
I am in no way an exo-urologist, but yeah, I think the exo-urologists are being phased out. Really, they're phasing themselves out because they've realised that if you can do it with a telescope, then that's going to be better for the patient. The minimally invasive surgery, as coined by John Wickham 4 or 5 decades ago. So the future, the trend. So I've put this as a thing I noticed during my time involved in the committee, and then as ultimately the chair of our national section of endourology for both training and practice. And I noticed it first in training. We had a residential course for trainees in their final year, who would go and be tutored and mentored by the country's experts. And when I was a trainee, people went to go and learn both the endoluminal and the exoluminal. So they would be learning also the laparoscopic skills. And then when I was on the committee, the market forces changed. People just didn't want to do both. They didn't feel comfortable doing both, and they perhaps thought that they were not going to end up doing both. So that was really the first sign. Trainees kind of know what they need to be trained in doing, and they were voting with their feet, saying, I want to do one or the other.
Mm.
And then I thought about it for practice, because it's not just about doing the procedure, it is about the whole of the rest of it. And all of that alongside the technical advance has become more complicated, MDTs, more difficult decisions, higher demands from the patient. And that was about knowledge. So I quite like this side. In particular, a surgeon is a doctor who can operate and knows when not to. We've all heard those sort of things: choose well, cut well, get well. And the Harvey Cushing quote that the actual surgery is the least part, because it's all about the decision. And then at one of our endourology meetings, when we were arguing this, I used this as part of my argument. You imagine that you're an endourologist and you're doing both. Let's imagine that you're doing 200 cases a year, 3/4 of them endoluminal, 1/4 of them exoluminal, but you've got a colleague who does 150 of the laparoscopic robotic ones. Then there's a tricky case. Who's going to do it? Once you start moving your trickier cases over to your colleague, how does that change the dynamic? And I think we're definitely seeing this in UK practice. We've certainly seen it at UCH, where it's totally super specialist, whatever you call it. And then at the bottom, that kind of dilemma: can you maintain both of those, both with surgical skill and the decision making? If you've got a colleague who's doing more. And then the red and the green box, what it might be like for discussing it with the patient. I need you to go and see somebody else for this, versus you were sent to see me because I do the complex cases. So it's a bit of a philosophical argument. And then I back that up, as you'll see now, with a little picture that I put together for it. So here's 3 surgeons. One of them is a lady, and they're operating side by side in a department with a bit of a mix of things. These black cases, these are complicated ones, but they're all doing a little bit of a mixture of it. But if you make a simple change and you go, look, you do those, I'll do these, everybody gets a greater amount of expertise. And then I draw everybody's attention to this one. We all get complications, unfortunately. And if you drop the ball, how does that feel to this surgeon when they're predominantly operating on these sorts of cases? And what would it feel like if it was actually part of their specific expertise? So I see that as the direction of travel. Endoluminal is all part of the natural circle of subspecialization.
Thank you for your great answer. And actually, just my last question to ask would be with the advancement of technology in this generation and era. So, what do you think of how do you vision the future of Endoluminal Endourology? Because I usually think that uro-oncology has always been the big guys and the focus of the urology field. Yet the burden of the stone and BPH is quite underestimated. So how do you vision to draw more attention to let others realize the long-term importance of endoluminal endourology?
So the future, I think, yes, the point there, and we are definitely seeing this now in the post-COVID recovery, that the majority of the exoluminal, and actually where a great deal of the infrastructure goes towards, is anything that is oncological and cancer. We have processes in the UK for 2-week wait referrals and very strict timelines, and that means that those patients are prioritized, and that's not wrong, but we do need to be aware of the flip side of the coin, that if you're prioritizing something, unless all of your resource is increasing, something else is getting deprioritized. So you're very right that we need to make the argument for the importance of this. blocked kidneys, whether it's by a stone, a stricture, endometriosis, oncological obstruction, that's causing loss of kidneys, and we've certainly seen more of that during the COVID recovery. So meetings where we can champion the cause and say that this is what we do. We are endoluminal endourologists. We don't just treat stones. We sort out a lot of things. In fact, one of the nice ways of putting it, when I presented lots of these data in one of our meetings locally, I had one of the senior surgeons say, well, you only do 3 operations. And the reply was, well, a trumpet has only got 3 buttons, but you can play a lot of music with a trumpet. So we've got shockwave, we've got ureteroscopy, and we've got PCNL, and it's working out how we can best play the tune with our trumpet to treat the greatest number of patients in the most successful way. And the future for that is going to be meetings. It's going to be collaboration. It's education. It's support. And then again, sort of slightly bizarrely, that the more subspecialists we are, the more we need generalists. You need somebody who's got an outside view and an overview. So there's plenty of scope, to use the pun again, for everybody to find their niche in endourology.
And thank you for your valuable time and comments on my questions. And I think the discussion today can inspire many young endourologists in Asia. And thank you so much. And I hope to see you again soon in person. Maybe I can invite you to so someday.
Yeah, the future of meeting is meeting. So that sounds like something to look forward to. Thank you very much for the invitation to join your meeting.
Thank you for your valuable time today. See you. Thank you.